Good afternoon. My name is Tracy Mroz. I'm from the University of Washington. I'm going to present a study on home health agency closures following implementation of the patient-driven groupings model and the emergence of the COVID-19 pandemic. I'd like to recognize my research team at the University of Washington, the University of Pittsburgh, and UCLA, as well as acknowledge funding from NIH, specifically NIA, for this study. So some quick background on the home health agency market. There are about 11,500 home health agencies that are Medicare certified and operating in 2020. We see that there has actually been a slight decline in the number of home health agencies over about the past decade. MedPAC reports an average of 1.7% decline in agencies between 2013 and 2019. And this is following what was initially a very rapid growth in home health agencies following implementation of prospective payment in 2000. So while over 99% of fee-for-service Medicare beneficiaries do live in a county that's served by at least one home health agency, the supply of home health agencies varies quite a bit by geographic region. Also, there's quite a bit of variation in terms of Medicare margins for home health agencies. So we see margins as low as 4.1% for freestanding agencies in the 25th percentile to up to 31.8% at that 75th percentile. So really quite a bit of variation. We tend to see that for-profit agencies have higher margins than nonprofit, rural agencies have higher margins than urban agencies, and there also tends to be higher margins among higher volume home health agencies compared to lower volume home health agencies, suggesting some efficiencies of scale. So we know from our prior research that previous policy has had impacts on the home health agency market. Some of the biggest ones are the implementation of the interim payment system in 1997 and the prospective payment system back in 2000. So research in this area showed that there was an increase in home health agency exits and a decrease in entrance during IPS. And that was followed by quite a drastic increase in entries and a decrease in exits during PPS. But this wasn't experienced in the same way across all types of agencies. So there was higher volatility in for-profit and freestanding home health agencies compared to nonprofit and hospital-based agencies during IPS and PPS. The rural payment add-ons are also a policy that has been off and on over the years, and this provides an episode-based percentage increase in that payment based on whether or not the agency is serving a rural residing Medicare beneficiary or not. And we've seen those payments have ranged as high as 10% to as low as nothing over the past couple of decades. And prior research has shown that supply changes do matter and are impacted by the amount of the rural add-on payments that are present. So the biggest change most recently is the impact of the implementation of the patient-driven groupings model. And this was happened in January of 2020. And I've included CMS's sort of go-to diagram for what the simplification of how you get to home health resource groups under the PDGM. And it's based on admission source and timing, clinical groupings and diagnosis, functional impairment level, and comorbidities. But concomitant with the implementation of PDGM was the COVID-19 pandemic, as cases in the United States were first identified just a few months later. And what we see from some of the initial reports by MedPAC is that the decline in volume of home health episodes and visits was attributed primarily due to the pandemic versus PDGM, based on looking at monthly trends. So from January to March of 2020, there was a slight decline in volume under PDGM compared to the prospective payment system in the same months in 2019. But that's in line with sort of a general trend and a slight decline over time. However, there was a huge drop, 80% drop in volume during April through May during those initial COVID impacts. However, by the summertime, by June through July, volume had really rebounded close to 2019 levels. And in August through December, volume stabilized. So again, consistent back to that sort of slowly declining utilization trends prior to 2020. However, we also saw that there were greater margins in 2020, and this was due in large part to payments related to the public health emergency. So the objective of this study was to really look at trends, not in volume, but rather in home health agency market exit overall and by different organizational characteristics of home health agencies, as well as the communities before and after implementation of PDGM, and within the context of that COVID-19 pandemic. We wanted to look and really describe trends in home health agency market exit overall and by the different organizational characteristics that might be associated with the likelihood of exiting the market. We also wanted to look at different community characteristics and really try to get a better understanding of what the impacts of the implementation of the patient-driven groupings model might be, but making sure we couch that within the context of the COVID-19 pandemic. So how did we do this? Well, we started out by doing a secondary analysis of publicly available data files. This was our quickest way to get information about the home health agency market. Our primary data source was the provider of services file, and this is a quarterly file from CMS, and we used data from Q1 2018 through Q2 of 2021. We also used the geographic variation public use file, the GVPUF. This is another publicly available CMS file that's provided on an annual basis to give us a better understanding of some of the market community characteristics. In order to get COVID data, we used USA Facts, which has been shown to provide some of the most accurate for the initial stages of the pandemic, county level case rates. So that is what we used, and those have been shown to be highly correlated with health outcomes or healthcare utilization. So that's why we use county level case rates. We also use data from the National Conference of State Legislatures to better understand, to get a sort of summary sense of which states were using certificate of need laws or moratoria around home health agencies. So here's just a summary of the key variables that we included in our models. So for policy, we looked at both policy and a policy times time interaction. We looked, like I had mentioned, using USA Facts data at COVID-19 county level population adjusted case rates. The home health agency organizational characteristics that we focused on in this analysis were ownership. We've seen that ownership, so profit, nonprofit, governmental, has been associated with changes in the market due to policy in the past. We also looked at provision of physical therapy services, whether they are provided not at all, yes, with in-house staff, yes, with contractors, or yes, a combination of staff, in-house staff and contractors, given the major change in payment incentivizing therapy before PDGM and then not after PDGM. We used PT services because they are the most common services compared to OT and speech language pathology services in terms of the rehab services available under the home health benefit. But at this, they were highly correlated with provision of other services. We also looked at whether or not an agency operated branches. So operation of branches or subunits was also associated under the analyses around IPS and PPS implementation. So we wanted to look at that as well. We also wanted to look at different types of service provision that a home health agency might offer as a way to have a different line of business other than just their home health under the Medicare benefit. So we also looked at whether or not the home health agency was certified as a hospice provider and whether or not it was qualified to provide outpatient therapy. And we also looked at hospital-based versus freestanding. We looked at a range of market characteristics, including CMS region, rural versus urban status, whether or not it was in a value-based purchasing state as part of the original 9-state demo, con laws or moratoria, and then some county level factors to better understand what Medicare looks like in that county in terms of utilization, percent of beneficiaries that are dual eligibles, and Medicare Advantage penetration. So we did a descriptive analysis of agencies that stayed in the market and agencies that left. But then our primary analysis was a linear mixed effects regression model with a random intercept for home health agency to account for the fact that we have repeated measures of whether or not the agency was in the market across quarters. So this mixed effects model really gives us risk differences of exiting the market. So I'm going to jump into the results here. What we see here is the number of active home health agencies, and we see sort of a steady decline over time. And then here I'm showing you the number of home health agencies exiting the market per quarter. So we see a range from about 70 agencies to about 155 agencies exiting per quarter. And now to the results of the regression model. I'm only going to present the results that, most of the results that are significant rather than all the results, but I'm happy to talk more about people who are interested in the full results. So first of all, what we're seeing here is coefficients are representing the risk differences for staying in the market. Okay, so a positive number represents a higher risk of staying in the market or staying active, where a negative number represents a lower risk of staying in the market or exiting the market. So here what we see is we see time in year. So we do year for interpretation, but we model by quarter. We see the differences in the change from 2018 to 2019 to 2021 to 2020 to 2021. We see a 4.4% decrease in the risk of staying in the market, so a higher market exit rate. We also see a significant difference for implementation of PDGM. And then we also see, but when we have this policy times time interaction, we have a positive coefficient of 2%. So what this really tells us, this is the change in the slope of the impact of the policy. So this is really the gradual change under PDGM versus that implementation of PDGM, that negative 3.9% is really the immediate impact. So then we look at COVID-19 case rates per capita, and here we actually do not see a significant result. So presenting the results from the regression model for home health agency organizational characteristics, we see that for-profit agencies have a 2% more likelihood to remain active in the market compared to nonprofit agencies, and governmental agencies are 3.2% less likely to remain in our market, so more likely to exit compared to nonprofit agencies. We also see a relationship for provision of therapy services, where PT services, when provided by staff, are 3.1% more likely to stay in the market, a non-significant relationship when provided solely by contractors, and a 3.5% increased risk of staying in the market when therapy services are provided by a combination of in-house staff and contractors. We see operation of branches, similar to prior research, is associated with 3.5% increase in risk of staying in the market, and qualifying for outpatient therapy as well is associated with a slight increased risk for staying in the market. Being certified as a hospice provider was not significant, and neither was being hospital-based versus freestanding. And then finally, for market characteristics, I'm not presenting rural versus urban participation in value-based purchasing, states with con laws or moratoria, primarily because these are not significant results. We did find some significant geographic variation, which is in line with sort of the vast amount of research in post-acute care literature showing geographic variation. So we did see in some CMS regions a much higher likelihood of staying in the market compared to our reference in Boston. Of course, this depends on where your reference region is, whether or not you're seeing higher or lower numbers. But the take home here is that we do see geographic variation. So in terms of how our results align with the MedPAC results on a decrease in volume, but an increase in margin, primarily due to the public health emergency versus the COVID pandemic, we actually do, versus the patient-driven groupings model, we actually did find an independent effect of the patient-driven groupings model outside of that COVID pandemic. So we see a bit of a lack of alignment here, just in terms of the number of home health agencies staying in the market. What we do need, though, is to look at really the longer-term impacts of the patient-driven groupings model as the COVID-19 pandemic continues to evolve and home health agencies learn to operate really under PDGM. We've seen from history that anytime there is a big policy change, it takes some adjustment time for agencies to be able to learn how to operate under the new system. And we generally will see some sort of increase in either volume and or an increase of profit margins afterwards. So we'll continue to monitor the supply of home health agencies. And this is particularly important for vulnerable populations. In addition, we'll want to look in the future to understand the overlapping impacts of other policies, such as the expansion of the HHBDP, as well as the sunset of the rural add-on payments, to see how those impact home health agency markets following the COVID pandemic as it starts to sort of settle down, we hope, as well as the maturation of PDGM. Finally, it's worth mentioning some limitations and how we're going to use those limitations to move into next steps of our research program. We were not able to conclude more detailed information on home health agencies, including quality outcomes and patient case mix for this study, due to the limitations of some of the public data and high amounts of missingness for some of the information that we can find at the aggregate home health agency level. We are also interested in looking at more granular community characteristics in the future. In this study, we could not look at inter-rural variation or socioeconomic deprivation indices, for example. There are many challenges in the home health agency arena to look at these sorts of community characteristics due to the way that home health agencies have service areas and how public data doesn't include information on volume from specific zip codes served. So analysis at this point using public data, including this type of information, could be very misleading. And then finally, we did also look at remaining in the market. So remaining active during the study timeframe, but our study didn't account for market exit and re-entry. And we do know that during the COVID pandemic, there was some of that. We do have 14 home health agencies that re-entered. So we don't think that this impacts the signal that we found in our results, although it's worth mentioning as a limitation. And finally, home health supply does not equal access. It is not the same thing. So that's important to keep in mind as well. Just the number of agencies doesn't account for service volume and what access really looks like for beneficiaries. So next steps. The list of references, and I'll be excited to take questions during the live session, and my email address is here if anyone has additional follow-up.